Acute abdominal pain is called acute abdomen. It is one of the most common emergency conditions. At the fact, there are multiple causes of acute abdomen. But here we will learn how to approach to a patient with acute abdomen step by step until we reach the most probable diagnosis. At the first, the abdomen is divided into 9 regions by 2 vertical and 2 horizontal lines. The 2 vertical lines extend in the mid-clavicular plane. 2 horizontal lines, the upper one located in midpoint between the suprasternal notch and symphysis pubis. The lower one crosses the iliac crest. This classification or this help us to understand what are the pathology occurs in each quadrant. But pain does not always map neatly to specific abdominal quadrants or regions. As we see in this picture, there are multiple causes of the pain in each region or each quadrant of the abdomen. We will start our approach by history and examination. By history, you must know the chronologically of the pain. For example, the acuity of the pain. Is it episodic or continuous? As a rule, the intermittent or episodic pain is usually not dangerous and not need emergent intervention. But this rule not totally accurate because acute coronary syndrome may be presented by intermittent epigastric pain. Also, the acuity of onset, as a general rule, the abrupt onset of pain, extremely abrupt onset, may indicate vascular catastrophe like rupture of AAA or viscous perforation. We must also know the relation between the pain and the food, either it relieved by food or exacerbated by food. Presence of associated symptoms, including nausea, vomiting, diarrhea, constipation, jaundice, dysuria, hematuria. We must know the past medical and past surgical history of this patient. If it's a woman, we must take detailed gynecological history. After we finish the history, we will do general examination and you must check the vital signs of the patient and do focused abdominal examination. And don't forget to do cardiopulmonary examination, as epigastric or right hypochondrial pain may be caused by pathology in the heart pathology like acute coronary syndrome or pneumonia. We will start now in the causes of the abdominal pain at the midline level. The first pathology that may lead to midline pain is peptic ulcer disease. From the history, the patient will come with epigastric pain, which is intermittent. Episodic may be triggered by eating. The rule is that is the absence of nausea and vomiting. But you must focus on the very important point is the presence of a history of non-steroidal anti-inflammatory drug use or H. pylori infection. By examination is unremarkable as the blood test usually unremarkable. But we must do H. pylori testing. The second cause is gastroenteritis. The patient comes with abdominal pain, typically very umbilical, often can be in nature, associated with nausea and vomiting, also diarrhea commonly present. There is no important risk factors for gastroenteritis. By examination, there will be mild to moderate generalized tenderness. Fever and signs of dehydration usually present. If you do routine tests, it will show elevated level of WBCs. So the gastroenteritis diagnosis is a clinical one. The third cause of abdominal pain is appendicitis. In appendicitis, if the patient comes early, it will present with dull aching pain in the pre-umbilical region, as there is irritation of the visceral layer of the peritoneum. If the patients come more late, the patient will present with shifting pain. The pain shifted from the pre-umbilical region to the right lower quadrant. and will become more localized as there is irritation of the parietal layer of the peritoneum, as the parietal layer supplied by somatic nerves. In appendicitis, by examination, you will find that there is a tenderness in a point called McBurney's point, the junction between the medial two-third and lateral third of a line connecting the umbilicus to the anterior superior iliac spine. Also, the patient is feverish, but if you find peritoneal signs like the rigidity of the abdomen, absence of bowel sound, this may indicate the patient enters in a complication in the form of viscous perforation, appendix perforation. Routine test will show elevated WBC. If you suspect appendicitis in any patient, you must order imaging study, either ultrasound or CT scan. The fourth cause of midline pain is pancreatitis, which is presented by epigastric pain radiating to the back, exacerbated by eating, relieved by sitting up and leaning forward, usually associated with nausea and vomiting. The risk factors of pancreatitis is alcoholic patient or gallstone, as these two make the majority of causes of pancreatitis. By examination, you may find that there is a mild to moderate epigastric tenderness, but patients, if the condition is so severe, may enter in shock, and you will find the signs of the shock. Pre-umbilical and flank chymosis may indicate that there is a hemorrhage secondary to pancreatic necrosis. By tests, laboratory tests, the most important thing you must focus on is the lipase enzyme. Lipase enzyme is typically elevated more than 3 times over the upper limit of normal range of lipase enzyme. Imaging study like CT is not typically necessary to make the diagnosis, but can be done for assess complications and look for gallstones. So, a rapid review. If the patient comes with pain starting in the pre-umbilical region shifted to the right lower quadrant, there is tenderness and rebound tenderness in the McBurney's point, you will suspect that this condition may be appendicitis. A characteristic for appendicitis is that nausea and vomiting and anorexia usually follow onset of pain, in contrast to gastroenteritis patient, in which the pain starts after nausea and vomiting. Also, in condition of gastroenteritis, the patient is usually dehydrated because there is nausea, vomiting, and also diarrhea. Epigastric pain due to BUD is usually episodic, actually radiated to the back. There is, in most cases, there is no nausea and there is no vomiting. Now we will talk about the causes of right hypochondrial pain. Right hypochondrial pain may be caused by multiple pathology, but the most common of them are biliary colic, acute cholecystitis, acute cholangitis, acute hepatitis. Biliary colic characterized by episodic intermittent pain in the right hypochondrium. This pain is often triggered by eating, but there is no jaundice. The risk factors for biliary colic is female sex, pregnancy, obesity, rapid weight loss, and diabetes. By examination, usually unremarkable. Also, routine blood tests usually unremarkable. In a condition of acute cholecystitis, there is a progressive pain over many hours. Nausea and vomiting also commonly present, but in acute cholecystitis there is no jaundice. The most important risk factor for acute cholecystitis is the known pre-existence of gallstones. By examination, the patient may be feverish. There is also tenderness in the right upper quadrant, right hypochondrium, with inspiration, which is called Murphy's signs. Murphy's signs means that when you apply your finger to the position of the gallbladder and ask the patient to take inspiration, the inspiration will cessate because there is a pressure or there is inflation of the lung. This inflated lung will pressure the liver, which will also pressure the gallbladder. Routine examination will show elevated level of WBC, but liver function tests in this condition usually normal or near normal. If you find that liver function tests are elevated, this indicates the condition not acute cholecystitis, but more maybe acute cholangitis. Acute cholangitis is inflammation of the biliary tract characterized by progressive pain over many hours. Nausea and vomiting are commonly present. Jaundice also commonly present. By examination in condition of acute cholangitis characterized by that the patient is very ill, high grade fever, drop of blood pressure, high heart rate and high temperature. Also, the patient may enter in mental state change. If you do a routine test, you will find there is elevated WBC, elevated bilirubin, mostly direct bilirubin more than indirect bilirubin. Alkaline phosphatase will be also elevated, but AST and ALT in most cases they are normal or near to normal. Acute hepatitis characterized by progressive pain over many hours to days. Nausea and vomiting are common. Jaundice also common. The risk factors for acute hepatitis are hepatitis viruses, particularly hepatitis virus A, alcoholic patient, acetaminophen toxicity, and autoimmune. By examination of a patient with acute hepatitis, fever can represent variety of findings related to liver dysfunction are possible, depending upon the severity and acuity of presentation. If we do laboratory tests, we will find there is elevated WBC level, but the characteristic between the four causes of right hypochondrial pain is the presence of high level of ST and ALT, and alkaline phosphatase is also high, bilirubin also high. If you suspect the patient is in acute hepatitis condition, you must order viral serology to know the cause. So, a rapid review of the causes of the upper right hypochondrial pain. The most common are acute hepatitis and acute cholangitis, cholecystitis, and biliary colic. How we can differentiate between them? Biliary colic presented with episodic intermittent pain. There is no nausea, no vomiting, no jaundice. Acute cholecystitis presented with nausea, vomiting, progressive continuous pain, but there is no jaundice, in contrast to acute cholangitis and acute hepatitis, which are presented with jaundice. If you find a patient with upper right hypochondrial pain who is very ill, high grade fever, and may in a shock condition, you must suspect acute cholangitis at first. Surgical abdomen implies that the underlying etiology requires an emergent evaluation by a surgeon. Examination of a surgical abdomen characterized by rigidity, severe tenderness to palpation, rebound tenderness, and absent bowel sounds. But not every surgical emergency presents with these surgical characteristics, as the condition of rupture of AAA not present with these characters. There are conditions you must put it at the first at your list when you see a patient with abdominal pain, but there is also shock. These conditions are acute cholangitis, bowel perforation, bowel infarction, ruptured ectopic pregnancy, ruptured AAA, splenic rupture, any condition with concurrent massive bleeding, and acute MI. At the end, to reach the cause of abdominal pain, start with history. Focus on onset of pain, character of pain, duration of this pain, either it's continuous or intermittent. It is episodic, abruptly onset, and associated symptoms. Don't forget to ask about the past medical and surgical history. Check the vital signs, and don't forget to do cardio and respiratory examination with abdominal examination.